I'm gonna start this session, and we have a four moderator, and me, and Dr. Khan, and Dr. An, and Dr. E, and we invite first speaker, and every person know where him, and he's a nearly pioneer and worldwide famous interventional, the cardiologist. And I'm gonna introduce Dr. Professor Morton Khan, and he will start a very interesting topic, how young cardiologists follow the pathway of success. And Dr. Khan, and could you please start your lecture?
Yes. Well, thank you very much. I'm going to share my screen here if I can find my talk. Let me see where it is. Hold on. Here it is. Top here. So I'm becoming a Zoomer. So there we go. Okay. Can you see and hear my screen?
Okay, wonderful. Great.
Okay. So first, thank you very much to the organizers, Dr. Ho, Dr. Park, and chairman and colleagues. It's a pleasure to be able to join you at this wonderful meeting. I look forward to working with you. I've met several of you in Lausanne, Switzerland, at Eric Eckhout's complications meeting, and it's always very much fun and educational. So Dr. Ho asked me if I would talk to the young cardiologists on how they should follow a pathway to success. I'll do my best to try and give them some words of wisdom. I hope they're tuned in, but it's words of wisdom for all of us. And I give this a similar talk to our graduating fellows every year, so I have some practice, and I think I know what they like. So let's just start right here. And I found this a little while ago on internet, and it's a fascinating image of an object that, as you look at it from different angles, changes in shape. And this, I think, reflects our concepts of moving through life with the idea that success will also depend on your definition of success and on your perception of success. Not so much what others see, but what you see in yourself. So just keep that in mind as we go through. Not everybody will see things the way you think they're supposed to be seen, but you are the arbitrator. Now, a bigger question for our young colleagues is, what does success look like to you? Because it may not look like that to me. I'm going in this direction, you're going in that direction, but there are several levels of hierarchy of needs that all of us must have, and that to achieve success, we really have to work our way through this hierarchy. So at the lowest level, you have to be able to take care of yourself, have something to eat, companionship, and so on. You have to be safe. You have to be psychologically safe. You have to be physically safe. You have to have employment that is safe. You have to have loving relationships. If you don't, you're not going to be successful. You have to have friends and family and intimacy. And then, of course, part of this will build your own self-esteem, confidence, achievement, and respect of others through those accomplishments and your behavior toward them. And then lastly, you'd like to rise above yourself and out for others and be creative, be spontaneous, solve problems, provide some benefits to the world, and leave it a better place than when you got here. Easy to say, hard to do, but something to think about. Now, it's often said that, some of my colleagues have sought to make a lot of money and thinking that a lot of money would bring them happiness. But in reality, if you look at this graph of average income and a happiness questionnaire from 1957 to 2000 in the US, it turns out that your income really wasn't related to your happiness score. And so many people who sought large amounts of income and revenue, all they did was buy more problems, not buy happiness. And I know if you don't have a certain minimal level, it's hard to be happy. But all of you cardiologists training and who have trained will have no problems with money That's not the biggest worry. Happiness is a little more of a challenge sometimes. Now, for our young colleagues, I think it's important to look ahead and look down the road. What do you want to do? This is not so easy to answer. Do you want to be in clinical practice alone? Are you interested in forming an academic career in cardiology and academic medicine? Do you envision yourself in some hybrid model in an academic clinical practice? And I know that while we're talking to fellows who are applying for fellowships, when asked this question, what do you want to do? They always pick this hybrid model. Well, I have to admit, I don't think there is a good hybrid model. I mean, either you're heavy clinical or you're heavy academic. If you can meld the two, that would be ideal. There are a few practices that can do that. And by identifying sort of which direction you're going, you can incorporate aspects of the other. So if you're going into clinical practice, it doesn't mean you can't do academic things. If you're going into academic cardiology, you must do clinical practice activities. And then ultimately, those individuals will have this hybrid model. Now, how does someone become successful in academic cardiology? I can just tell you my pathway real briefly, and maybe that will give you some direction. So I think the three components that make a successful academic cardiologist are these. One, that there is some research being performed or having been performed, is published, and people know that you're working in projects to move the field forward. Second thing in academics is to be a good teacher, a communicator, a presenter, be someone that people would like to hear from and like to talk to and learn something from. And lastly, to put these two first components in perspective, you have to be able to write them down, submit them, and have them published somewhere. Now, I always tell our fellows that every article has a home. A magazine, but it's a home. If you just write the abstract and you don't publish, all you've done is rent the home. You don't own the home. Once you write it and publish it in a journal, you now own it. So writing is key. And I would say of the three things, it's the hardest. I know that sounds strange, but writing things down every day is what needs to be done. So let's talk about the kind of research you can do. In interventional cardiology, it's very hard to separate bench research, career, and also work in the clinical arena doing interventions. The best kind of research in the arena of interventional cardiology would be that data collection systems that are coupled to your clinical activity. If you work in the cath lab, measure things. If you work in the clinic, acquire data from the clinical aspects of testing, or another fashion in which you can couple your clinical work with your research work. If you have to leave the clinic to go into the bench lab and do your research, you double the time it takes to generate both research and clinical value. So just keep it in mind. I would say to develop a tool that measures something or use a tool that measures something. In the cath lab, we have physiology, we have hemodynamics, you can bring in the echo lab into the cath lab, you can bring in your non-invasive tools immediately before or after, but acquire quantitative information and continuously ask a question. Now, in that same mode, when your research is underway, then become an expert in the field that you're doing your research. Become a teacher, and let your colleagues know that you are an expert in a certain field. Then, obviously, it would make sense to be an expert in the field in which your research is being performed, and be a good communicator. And I'll talk about a couple of keys on communication in just a moment. But a good, clear presenter, good conveyor of information, caring about your audience's ability to absorb the information you're giving them is key to being a good teacher. And then writing. I'm just going to touch on that for a moment. So from the earliest days, I don't know how this happened, but I used to write things, case reports, or I'd write up little projects in medical school. And then I loved to see the work get published. And it didn't matter where it got published initially. And I would encourage all the fellows to write things down and submit them for publications. If they're new to you, they may be new to somebody else, or if they're new to you and you learn something, some of the other fellows would like to read what you discovered. But you have to sit down every day for a certain amount of time. It doesn't have to be a long time, half an hour, maybe more, and write something. Work on the project, continuously edit it, and then ask a mentor to come and edit your writing behind you, because it's often not automatic that you understand what the difference is between casual writing and scientific writing. So I can remember my first case report with a gentleman named Bill Grossman, published a textbook on cath. He ripped it up with a red pencil, and I said, okay, I have to start all over. And through that method, I learned a little bit more about writing each time. So that's my recommendation for the academic pathway. Now, what about the clinical pathway and success in clinical practice? Well, I've divided success into three big blocks. In order to be successful, you have to have good clinical acumen. You have to know your stuff, be an excellent clinician, and not just in cardiology, in a lot of medical other areas that require interaction with cardiology. Be a good generalist and be a good specialist. You have to cultivate a personality for clinical practice. Not everybody enjoys interacting with people as much as some others. I prefer being in the laboratory often, but I do interact well with patients and with my faculty. But this is something you'll have to consider. And I have a few clues for us to help us down the pathway of personality. And lastly, and I know this sounds odd, but you must be a good time manager if you're going to be successful in clinical practice. You have only so many hours, and if you don't efficiently use them, you will not rise to the level of success that you really want to achieve if you're not a good time manager. So we'll talk more, but those are the three components. And if you look at your colleagues who are in clinical practice and who are successful, what do you see? You see a guy who knows his stuff. You can ask him almost any question in a clinical setting. He'll be able to sort through it and give you an excellent answer. You see the same guy with a personality that enjoys doing that. He enjoys mixing it up with other people, and people enjoy being around him. And lastly, he comes, he goes. He doesn't waste time. He does the job, moves on to the next project. It's a very good and acquired skill set that this clinician who is successful in practice has. And you too can do the same. Okay, let's prioritize the goals if you're going to get down the successful pathway. Either one, either clinical or academic, you still need to prioritize goals. And I want to emphasize to all the fellows, family first. Family life satisfaction is key. If you don't have a good home life, you're going to have a miserable career life, because you'll bring that to work. You'll struggle. So try and make that work. What does the family want? Well, people talk about quality time. That family wants quantity time. And quantity for children and young adults who are you're their parent, they need you to be there. And when you're there, be in the moment. None of this minuscule quality time. I'm going to give you the best 5 minutes of my day. Now, when you turn your attention to your work-life satisfaction, these are actually easier. So you will have nearly automatic financial success if you're in cardiology. You're in the top 1% of the world's employed professionals. You'll be paid for your skills. I don't think this should be a major concern. You'll want peer recognition through what methods that I just spoke about, and we'll speak about again, but you will get peer recognition by successful interactions. You want to pursue intellectual stimulation because this is what you must do to keep up with the field. If you lag behind, you're not going to be that good a specialist. So intellectual stimulation is key. And lastly, if you have the opportunity, you should take on leadership roles, innovation in your field for either in the lab or out of the lab, and continue to move the work forward through these skill sets. Now, I want to return to the family satisfaction. Here are 6 little phrases that should help you, and they're self-explanatory. Happy wife, happy life. So if you don't look good, I don't look good. If you're not happy, I'm not happy. That's my home saying. I try and be home by 6. Why 6? That's the dinner hour over here. And if I can't get home by 6, I better have a very good reason. There's stuff you do at work and there's stuff you do at home, and you can't cross the two. You have a family, be there for them. Communicate. Now, that means not just coming home for dinner, but communicate the issues, engage the family, engage the children. Let them know that you're part of their life. Keep your spouse as a business partner, and I would say maximize vacations, because you are going to work hard. You are going to have long hours. You will not be able to do all the things on this list that I mentioned. So you'll have to add quality to your life through vacations. Some people don't do that so well. Now, on the job, I just want you to remember that efficient work trumps hard work. That is, working hard and inefficiently doesn't get you anywhere. You're just spinning a tire in the mud. You need to select where you can do the best and most efficient work. If you can delegate tasks, especially clerical tasks, do so always. You need to be at work with respecting your partners, respecting your patients, supporting your individuals who are your administrative people, and you must lead them. You are the leader and the revenue generator for that group. Again, at work, as the same as at home, you must communicate with the people there. Talk to them, learn about them, share your thoughts, but be clear in what it is you're doing and what you want to be doing. And always give your best. Don't do it halfway. Now, one thing I tell my fellows, and because they're doctors, and all doctors are late, I say this is not a habit that you should keep. Habitual lateness tells others they're not important. Spouses, coworkers, my bosses, they hate it when you're late. They may not tell you, but I know they do. I do. You have to be honest about your time. Multitasking is not okay if you can't finish the important task at hand. And you must re-examine what you think is efficiency for you. Is there a reason you can't get home by 6? Is there a reason you can't get to these meetings? Are you having trouble? And if you're late, you better figure out why and try not to do that, because as the first sentence says, people don't like it if you're late. Now, ask yourself, I'm going to be successful. Am I a time waster? Because I have only a certain amount of time in my life. Some people waste 2 hours a day at least, or maybe more. What are the signs that you're a time waster? Your desk is a mess. Your files are cluttered. You're unorganized on your computer. You can't find things in a hurry when you need them. You miss appointments. You need to reschedule. You're unprepared to go to meetings. You volunteer to do things other people should do. That is, you don't say no when you should say no. And you're tired and you're unable to concentrate. So ask yourself, are you a time waster? And if you are, you can start to address each of these things, and you should. General Dwight Eisenhower, famous general of World War II, former president of the United States in 1955, he put together what his concept of time management was in a very brief thing here. He said, I have two kinds of problems, the urgent and the unimportant. The urgent are not important, and the important are never urgent. So he broke this into 4 quadrants. He says, these are done in quadrant 1, important to do urgently. These are done immediately, and they're done by me. In the not urgent quadrant, up here in the upper right, these non-urgent but important plans get an end date, they get an outline, and they are also done by him personally. He takes charge of running that problem. On the bottom here are not important issues. So if they're not important, delegate whenever you can. Delegate. Okay? So interruptions, meetings, activities, delegate your schedule to somebody to keep the unimportant stuff away from your door. And this is key. One of the most interesting things I saw on this list was email. You should not be spending all day going through your email. I would say set up a time, finite time, and go. Most of your email is not important, could be delegated. You may think it's urgent, but let somebody think about what it is. And some of the meetings fall into that category. Lastly, if it's not important and not urgent, get rid of it. You don't need it. You shouldn't do it. May be fun, but it's not moving your career forward, and it's often trivial. And That includes, again, some of the emails, some phone calls, people who stop by your office just to take your time up. You'll have to be in charge of your own schedule and make that work. I thought this was a key. I like to keep a neat office. Here's my partner's office, and I'm just down the hall. Here's my office. I think I can find things. It's comfortable. I'm organized. I get things done. My partner here on the left is in there somewhere, but I may not see it today. So in the workplace and at home, but mostly the workplace, you need to cultivate good personal traits. Remember, this is the middle box of that success in clinical practice. You should be available. That is, be there and actually be there and anticipate when possible, even before you're needed. Be affable. That means be nice. Be effective. That means get it done, do what you say, and preferably today. And I think dependable means you're going to get it done, and people know when you say you're going to do it, it's done. There are many of my colleagues who talk about projects and talk about doing things, but I never see the end product. And so talk is cheap. You should be honest at all times and timely with your communications, your referrals, your consultations. And here's the hardest one. Learn how to say no nicely. You can't do everything people ask you, and you can't do it all at once, and you can't do it at one time. So you're going to have to say, I would love to do that project, or I would love to see that patient, but at this moment, I cannot. But I will if I can, and let's make arrangements. So learn to say no nicely is an art form. I've listed here for you habits of successful people on the left and habits of unsuccessful people on the right. I just want to point out 3 or 4 of them. I think it's important to embrace change to be successful. Our field changes, the world changes. I mean, who would have thought we'd enter into a pandemic? You can't live with fear of change and stick to old ways. Radial artery catheterization in the United States was one of those failures to embrace change until recently. I think it's important to forgive others. Grudge holding is a bad habit. Holding a grudge is like you drinking poison and hoping the person dies. It's not a very smart road. It takes a lot of energy. And then the last one I wanted to talk to you about are these 2. Have a sense of gratitude and appreciation for the world around you, not a sense of I'm entitled to do this. People respect you for that. And lastly, set goals and plans. And we've been talking about that all along. So goals and plans for success. Okay. Now, just a few brief words of wisdom because I've gone over time a little bit. Here's a famous African proverb. Think about this. If you want to go fast, go alone. If you want to go far, you go with others. And remember, cardiology is actually a team sport. We should engage our colleagues and go far. Tell my fellows, look, we've got things to do. I don't have time to wait for the deadlines. I get it done before the deadline. I get it done as efficiently as I can, and I don't wait till the last minute. It's almost the equivalent of being late sometimes. I don't have time to wait for deadlines. As a consultant in cardiology, this should be your motto. Be the one they want. You be the person that they want to call, not your competitor, not somebody down at the other hospital. You be the one they want to call. And here's my ultimate favorite phrase to give to my fellows for life communications. All of our communications with everybody around us, and especially at meetings, brevity, clarity, and wit. Be brief, be clear, and make it pleasant to hear what you have to say. If you have a joke in there, occasionally it's the right time, but at least be brief and be clear. Fellows, if you can't state your question in a Twitter format, then it's not a question, it's a speech. Get to the point first, and then help communicate the rest of it. Don't give me a long shaggy dog story. Twitter format. Okay, I learned this recently that there's ways to mentor my young colleagues who are millennials. These are these are young adults who were born after 1985, and they have different ways to learn. And we have to get ready that millennials like to embrace innovation. They like autonomy. They like purpose. They like leadership, and they like diversity. And I've tried to incorporate that into my methods of teaching, because our fellows are millennials. And this is my new millennial uniform for going on the floors and doing our clinical rounds. We're lucky. We don't have much COVID, but it does create some challenge. We're almost done, and I want every one of us to remember this. In arguments with your spouse, I want you to ask yourself, do I want to be right, or do I want to be happy? Sometimes you can't be both. And lastly here, this is one of my fellows who was thinking about the cath lab when he came in, and his advice to his colleagues and fellows, he said, show up, even if you don't like the cath lab, pretend you like it and be there. And then I had to tell him, I said, look, sincerity is everything. And once you learn to fake that, you've got it made. I wish I was there in person, because I'll bet there's somebody laughing in the background. And finally, for the fellows, I know that you will all achieve great success. There is no failure in cardiology training. There is no failure in the cardiology career. And I hope my brief words have helped you out and you've enjoyed hearing some keys to the pathway. I'm going to say thank you very much.
Okay, thank you very much, Dr. Morton KERN. I think this is a very impressive and mind-touching and somewhat philosophical lecture. Before moving to second part of a case presentation, we will receive one or two questions from the audience. Any question from audience, especially young fellow?
I hope we have a few young fellows on the call.
Any question or any
Dr.
comment?
KERN,
Okay.
I am Jung Min from Asan Medical Centers. Thank you for a very nice presentation. You give us a lot of things to me. So one of my question is, what is your memorable time point or memorable things you put you in the successful pathway in your doctor's career and researcher's career?
Yes. It's such a nice question. So the thing that triggered me the most in a research pathway is when somebody said, go to work in the cath lab, and I want you to join this project where you measure coronary sinus blood flow. And I said, I never heard of that. They said, that's fine. You go in, you learn how to do it, and you measure it. So I did that. I went in, I learned how to measure, and I said, oh, this is the key to learning how to make changes and understanding things by measuring what happens to coronary sinus blood flow. Now, what it ended up doing was falling in love with the concept and not the technology. I fell in love with understanding the coronary circulation, and then the technology moved on. I thought the coronary sinus measurement would be the key and last forever. It didn't last 5 years, because then Doppler flow came in, and then pressure wire came in, and now it's going to be virtual FFR on the angiogram. So, but all of it still applies to a concept. So when I found out I loved a concept and I could measure things, that was the spark that started me off on the academic path. And I remember finishing my fellowship and looking, should I go down the clinical pathway or should I go down the academic pathway? I said, well, let me go down the academic pathway just for a few more years until I finish these two projects. I really liked them. And after a couple of years, I was hooked. I couldn't change direction.
Can I ask?
It may happen to some of the adults. Yes.
Can I ask one question to Morton KERN? Thank you, sir, for excellent and thought-provoking lecture for the young cardiologist. Can I ask one question? What is the synonym or difference between successness and satisfaction about the profession? Success and satisfaction.
That's your question. The difference between satisfaction and
success.
Success.
Yeah.
Okay, so the definition of success, again, depends on the person and his point of view, not my point of view. So satisfaction is part of the success. So remember, there are many components that go into that person's success on that hierarchy of needs. So satisfaction is achieving several of those needs, and success is accomplishing all of them to your point of self-realization, where you think, I've achieved my goal. Now, some people never are satisfied with success, whereas others say, well, I've been successful and I think I'm done. But many continue to go. So it's a real personal decision how far up the triangle of hierarchy of needs one has to travel. It's a little bit philosophical, but I think that's what you asked me.
Okay. Can I also ask one question? In our career, we always up and down, always up and down. Sometimes we encounter lots of crises. Do you have any advice to give us how could we handle those crises or downside in the life better?
Oh, so that's a very good question. How do you manage crisis? And I'm not a pro on this. I'm not an expert, but I can just give you my own view. So you will have personal crises in your life. You will have professional crises in your life, and you will have clinical crises in your life. Personal crises are unavoidable. Somebody gets sick, somebody gets divorced, somebody gets cancer, somebody has a problem. You have to, I would recommend you read a book by Harold Kushner, rabbi, talks about when bad things happen to good people. And it takes you into the realm of accepting fate, understanding limitations of what you can do, and then working with the people, working with the person. He uses a phrase at all times, which I really liked, and he says, human beings are God's language. And so God communicates with us through people and through our interactions with them. Second crisis is professional. That's something that is a function of economics, your partners, your work life, and you'll have to decide if the job has changed through forces not your own, and whether you need to stay in that pathway in that job or find a new job. So professional crises are a little more manageable, although they're equally painful. And lastly was so that was personal, professional. I forgot what my third one was, but the third crisis is of the clinical nature. When you're in the hospital dealing with a very critically ill patient or some other crisis on clinical needs, that's probably the easiest one. It does also generate angst and psychological pain, but it's manageable. You're trained to manage that crisis. So that's comfortable, more comfortable than the professional, which is a little bit better than the personal. Personal, I think, is the hardest, and it has the most impact on your life. And then the professional crisis, and then the clinical crisis. It's perhaps a little simplified, but you asked, I did my best.
Thank you very much. Thank you, Professor.
Okay, great. Any last question for Dr. Morton KERN? Any comment? Okay. Because of a time limit, we're gonna move to the second part of this wonderful section, and the second part is composed of very diverse case presentation. I'm gonna ask the co-moderator, Dr. An, Dr. Yu, could you read the second part of a case presentation?
So, hi, may I introduce the first presenter, Dr. Ivan Zheng, which is come from Hong Kong Princess Margaret Hospital. So, please, Dr. Zheng.
Okay, can you see the slide?
Yes, we can see.
Yes, yes.
Okay. So hello, hello, Chairman, ladies and gentlemen. I'm Dr. Ivan Zhang from Hong Kong. I would like to thank the organizing committee for giving me a chance to present one of my most unforgettable left main PCI cases with mechanical circulatory supports. So let's begin with some introduction. Left main disease is still a great challenge to all of us, especially in those patients who present acutely with unstable hemodynamics. Significant left main stenosis is found in around 5% of patients who undergo coronary angiogram, and 70% of them are associated with multi-vessel disease. Without treatment, the 3-year survival is as low as around 40%, and data on the use of PCI in patients with acute MI due to left main disease are limited. And not surprisingly, the outcome in such patients are worse than those stable cases, and observational studies have reported in-hospital mortality rates up to around 20%. So with all this background information, I would like to begin my case presentation. My case was an 81-year-old lady with history of diabetes, hypertension, and hyperlipidemia. She was admitted to our hospital for a few days' history of chest pain and shortness of breath. Physical examination showed evidence of heart failure, and her chest X-ray was congested. The first set of troponin I after admission was already markedly elevated. So the ECG on admission showed 1 millimeter and ST elevation at lead ABR, and also diffuse ST depression and T-wave inversion over the inferior and lateral leads, which may signify a severe left main disease. So the echocardiogram showed a mildly dilated LV with impaired systolic function. There was global hypokinesia and also moderate mitral regurgitation. So diagnostic angiogram was urgently performed, which showed ostial left main severe stenosis with pressure damping even with a 5-French JL4 diagnostic catheter. The coronary arteries were heavily calcified. There was a bifurcation lesion at the distal left main with a 90% stenosis at the ostial circumflex and a heavily calcified 80% stenosis along the proximal to mid-LAD. So you can also see the retrograde blood flow to the RCA. The angiogram to the RCA show a CTO at near the ostium. So referring to the guidelines, such a severe disease, especially for diabetic patients, should consider bypass surgery instead of PCI, but this only applies to stable patients with low surgical risk. So our plan was to stabilize the patient as far as possible before the surgery. Her syntax score was 39, and definitely bypass surgery should be the first choice. But in my hospital, there was no on-site cardiothoracic surgeon. So if we wanted to refer a patient for bypass surgery, then we had to transfer the patient to another hospital, and usually it takes 1 to 2 weeks of time. However, she developed cardiac shock and also acute pulmonary edema 2 days later, 2 days after the coronary angiogram, and required urgent endotracheal intubation, mechanical ventilation, and also high-dose allotropic support. So we consulted the surgeon for urgent bypass, but replied that it was too risky for inter-hospital transfer. So after getting consent from patient's relative, we proceed to emergency high-risk left main PCI. So first we insert IBP and then start the procedure with a 7 French JL4 guiding catheter. We choose JL4 and had to carefully manipulate it in order not to dissect the left main. The LAD was wired with a Xeon blue guide wire, and then pull over to the left main ostium with a 2.5 semi-compliant balloon. And then quickly we stent the left main with a 4-0 drug urethane stent. So this was the angiogram after left main stenting with no more pressure damping when the guiding catheter engaged into it. So the mid-LAD was stented with another drug urethane stent. So we performed some post-dilatation to the left main, and also the LAD stent using NC balloons. And IVUS image showed good apposition in both stents. Sorry, I did not have the IVUS image here. We plan to leave the left main bifurcation PCI to a later stage. Although there's no data to support impeller is superior to IBP, but we still want to use impeller as we do believe IBP may not be enough to support the patient for such a prolonged and complicated procedure. But impeller at that moment was not available in my cath lab, so we staged the procedure and to arrange the device. The hemodynamics improved after the first PCI. She was transferred back to CCU and able to wean off ventilator and IBP over a few days. However, the blood pressure was still low and required inotropic support again. And also, she developed acute kidney injury and also ventricular stent still required temporary placing. So we proceed to the stage PCI, and this time with impeller. We inserted impeller 2.5 into the LV. Impeller 2.5 was used instead of CP because in Hong Kong, due to some reimbursement issues, the patient need to pay for the impeller themselves. So after some discussion, our patient's relative decided to go for a triple 2.5 device. So this time, a 7 French EBU 3.5 guiding catheter was used and engaged into the left main without any pressure damping. Both the LAD and circumflex were wired, and we did an IFUS pullback from the LAD, which showed moderate disease over the distal left main and a very tight and calcified lesion. This is the image of the osteo circumflex, which saw a very calcified and tight lesion at the osteo circumflex. So when we try to pull back to the circumflex, it caused a 2.25 NC balloon to rupture. And after some repeated attempts, and finally it was pre-dilated with a 2.5 high pressure balloon. These were the hemodynamic records before and during the pullback to the ostium circumflex. The patient developed bradycardia and also hypotension with mean arterial pressure dropped to around 30 millimeter mercury only. This was essentially a PEA arrest without the impeller support. So initially, we planned to do a DK crush. However, the stent could not be further advanced into the circumflex due to the acute bend and also calcification. And the patient developed bradycardia and hypotension again. And I think if I take out the stent at that time, it may dislodge easily due to the calcium and also the angulation. So we decided to deploy the stent there and change our strategy to culotte stenting. So we rewired the LAD and opened up the stent strap. The left main LAD segment was then stented with another DES. We did the kissing balloon inflation and then caught the left main with a 4.0 high pressure balloon. So the final angiogram saw a TIMI3 flow in the left coronary arteries. We decided not to touch the RCA in view of the advanced age of our patients and also a good collateral blood flow to the RCA. So the patient recovered quite well after the second PCI with improving heart and organ functions. She was able to wean off impeller support on the next day after PCI. She was given a course of cardiac rehab and then transferred to convalescence bed for further rehabilitation. We believe the culprit of the deterioration was the osteo left main and LAD lesion, which also supplied the retrograde to RCA. So we aimed at restoring the left main and LAD blood flow during the first PCI. Performing left main bifurcation stenting at that juncture without any impeller support was too risky, and hence we decided to leave it to a second stage. The decision was later proved to be correct that the patient clearly developed PEA arrest during the second PCI, even with impeller support. So cardiogenic shock is still one of our biggest challenge. It complicates 5 to 10% of cases of AMI and is the leading cause of death after MI. Reversing the downward spiral by PCI or mechanical support, we hope to improve the cardiac output and also clinical outcome. But despite the advance in technology, the 1-year mortality rate is still around 50%. In the past, we didn't have any good definition and staging for cardiogenic shock, unlike other conditions like heart failure and myocardial infarction. Until recently, a proper staging system was proposed. Higher stage is associated with increased hospital mortality from around 3% in stage A up to 67% for stage E. So the question is how to identify those patients who may benefit from mechanical support from this mixture of patients. About 50% of patients who are at early stage of cardiogenic shock will survive without any mechanical support, while in about 30% of patients who are at late stage, death is likely to occur even with any support. Inserting a device in these two groups will be of no benefit. leaving a subgroup here around 20% where mechanical support could improve the survival. So in the past, those study group all cardiogenic shock patients in different stages together for analysis. This may explain why routinely insert IBP may not improve the outcome. So the problem is how to identify those potential candidates. So this case also illustrates two forms of mechanical circulatory support, which are IABP and impeller. We did not consider VA ECMO in this case in view of the advanced age of the patient, and we thought it was too traumatic for her. Both IBP and impeller had their pros and cons. IBP is the most commonly used support device because it is readily available and can be inserted easily and rapidly, and is less expensive than impeller, but it's only capable to generate modest hemodynamic support, and also the optimal timing of placement is still unknown. Impeller theoretically provides a better circulatory support, especially when a patient nearly develops transient cardiac arrest during the procedure, but still lack of any evidence on better clinical outcome compared with IBP. So talking about evidence, data are still limited. Some trials are small scale, observational, and also based on registry data. Patients selected for mechanical support are more ill, which may account for the poor outcome, like bleeding, MI, and stroke, and even death. The definition of cardiac shock was not well defined, as I mentioned before. The timing of implantation of impeller or IBP was not standardized in clinical trials. And recent studies suggest the early initiation of support before starting any inotropes or PCI is independently associated with improved survival rates. So apart from the door to balloon time, in cardiac shock patients, the door to support time may be of even more importance. So currently in the ESC guideline, it's only a class 2A indication to use mechanical support in selected patients, but without any preference for which device. So all this suggests a properly designed RCT is needed before any conclusion on the effectiveness of mechanical support can be made. So in conclusion, ladies and gentlemen, I presented a very high-risk case who had a severe left main and triple vessel disease and presented with cardiac shock and multi-organ failure. We successfully performed PCI in 2 stages using 2 different mechanical support devices, namely IABP and also impeller, with satisfactory outcome. We do believe mechanical support devices have their role in clinical settings, but we still need to await for good evidence from properly designed randomized trial. So this is the end of my presentation. And this is my team in my hospital, and thank you so much for their support over the past year. Thank you very much.
Okay, thanks, Dr. Zheng, for your nice presentation. Any comments or questions from our panelists or audience?
Well, I have a couple of comments which might get the questions stimulated from the audience. So first of all, excellent case, very challenging. Usually these don't end up so well because if you have total right and critical left main, often the myocardium can't tolerate it. So 2 things. One, I think support key up front early was a good idea. You picked the balloon pump because perhaps the impeller wasn't available. I think you have to pick something, and I don't know if it would have made a difference. You did a good job of staging left main LAD followed by the circumflex. Circumflex also critically narrowed and important because it supplied part of the left and the inferior wall. I think that in the performance of this, obviously if surgery had been available, you would have achieved complete revascularization. They would have put her on the pump. But many surgeons would say no for advanced age, diffuse disease, comorbidities. So I think this approach has to be done. One might ask, because of the heavy calcium, should you do rotoblator in this setting? I think if you can get by without it, it's better. And the other option is, the other caveat regarding support pumps is, if you have a critical lesion, you cannot pump blood through that stenosis very well with almost any device, including impella. So the support is on the systemic side of cardiac output, perfusion of the kidneys and brain, unloading of the heart, and then you follow that with revascularization, open up that, and then the heart receives its perfusion, and the patient will do okay. I think that the second time showed that you really did need support because of the critical hemodynamic changes seen with the stent of the circ. So I'll just stop there and I say I think the hemodynamics favor of the Impella over balloon pump, and they favor ECMO if you really need super strong support over all the others as well.
It's great. I think I have one question to the Dr. Morton Khan, and I think this case is one of a typical example of MCS supported very high risk complex case. So data are still limited about the timing and the type of MCS, and so if you're going to available IVP and MCS and ECMO, what is your prefer? So such
So if I have that patient and I have all three available, I have balloon, I have Impella, I have ECMO, I would, if the patient was not in extremis, really crashing, I would pick Impella. It gives me the biggest bang for the buck. It's still, if the artery can tolerate it, it's good. The balloon pump is modest at best. More, it barely unloads. It's only a ½ liter of cardiac output advance, but it can get us through. Remember, it used to get us through left mains all the time. But the Impella, it would be my choice for this particular case on both occasions if I could. And I rarely pick out ECMO or VA ECMO unless after Impella, after revascularization, the patient is still dying, then I'll put him on VA ECMO and hope that we can get him some time for myocardial recovery. Now, I just want to say a word about data sets. So in the field of cardiogenic shock, the data is mixed and the outcomes are mixed and the results are mixed. And you can't really sort out from any single study what's the best one when you mix up patients who are almost 100% likely to die with patients who are 100% likely to survive. So if you mix these groups together, you don't get a clear picture of the benefit of a support device. And until we start to randomize based on shock stage and standardization of time window to arrival, it's going to be a very muddy set of water that we swim in.
Congratulations to Ivan Tang, the very nice works. So I think I can do better than you if I met such kind of patient. But I have one question, the very common comment. So actually you did the procedure very fast. It's very nice, but sometimes we need some time to restore the anterior flow to the left main, to the LAD and circumflex system. So if some operators only focusing on put the stenting, but sometimes we need to disengage the guiding catheter and stabilize the blood flow, anterior blood flow, and vital blood pressure. Sometimes it is important. But anyway, you did a very great job.
Thank you for a comment. Yeah.
I have an opinion. I have the same opinion with Dr. Morton Khan. Because of the Impella is the best advantage in this type of the critical patient, because you can do the complete revascularization using the Impella, because you don't worry about the hemodynamic impairment during Impella uses. Otherwise, IVP. So in the first stage, how about using the Impella devices for your first PCI?
Yes.
Because this patient is already cardiogenic shock. So
yes.
It's an indication that Impella. So you can use other devices like rotational colectomy or the lithotripsy to complete revascularization. So I recommend, in my opinion, I recommend the Impella device other than IVP in this patient.
Yes, we did want to use Impella, but because at that time, at that moment, it was not available in our cath lab, so we have to go for some support. So the only choice is IVP, so we use the IVP. And because without Impella, we are not brave enough to do the left main bifurcation at that time, so we staged the procedure. So if we have impeller during the first PCI, then we will proceed to impeller and then complete the revascularization to the left side. Yes.
Let me ask, do you think that the tube 5 impella was different than a CP impella? I know that the cost issue was brought up by the family reasonably, but do you think it would have changed anything if you'd had the higher output with the CP?
Yes, but most of the time we are using CP, but some patients, maybe because of financial issue, and also sometimes we do an angiogram to the femoral artery first. If the femoral artery is not that big, then we would go for 2.5, but most of the time we use a CP device.
Yeah.
Well, it depends on the patient status. As you know, the Asian older people with a small status, impaired CP is too big in their ventricle.
Yeah.
So in the small status patient, I like to use impaired 2.5 other than impaired CP.
That's a good idea.
Hi, Ivan.
Hi.
No,
Hi, this is Alfred.
Hello.
First of all, congratulations for your result. This is an excellent case. As the other panelists said, I don't think I can do any better. I have one question and I have a little comment, so to hopefully ignite further discussions. My question is, what was your evidence supporting the decision that the second PCI was needed to salvage this patient? Because I am not quite sure if I have missed any slides, but apparently when you go in the second time, the flow in the LAD, left main, and circumflexor looks quite well, actually. Although quite obviously the osteocirc is severely stenosed, but apparently there are TME3 flow all over in the left system. So I'm not quite sure if I have missed anything, but is there any other causes for the patient crashing before the second PCI? And if that is not the case, I mean, in general, what is your approach in doing such staged PCI in these kind of patients? Because obviously with a single viable coronary artery of the left main, the patient is going to crash anyway when you do the second PCI, because the left main is supplying blood supply to the whole heart. So the timing of this second PCI is obviously crucial. So my question is, how do you, in general, pick the time for the second wait overnight and then do it the next day, or would you give it like a week or so for the patient to further stabilize if the patient can survive, and then do the second PCI? And then my comment, this is an old patient. Her left main looks quite big. I heard that you've tried doing a crushing technique in the left main bifurcation, but would you, if you are to choose again, would you choose culotte approach in the first place? I mean, her left main looks quite big. You don't want to prolong the procedure. Culotte apparently is easier and make the procedure shorter. And apparently the patient don't have much time to develop ISR in the future. So I mean, from hindsight, would you have chosen culotte technique instead?
So thank you for the questions. So to answer your second question, I think if I do the patient, if we do a patient right, if the patient is on table now, I will still choose a culotte stenting because it's faster for me to revise so many times. For the timing of doing the left main bifurcation, we don't have any evidence because at that moment when we see the patients, having shock, we have ruled out other cause, no hemorrhagic component, no sepsis. The only thing we can think of is the cardiogenic shock. So we think we do need to open up the circumflex to see any improvement. So, but if we are talking about evidence, then actually we don't have any evidence. For the timing, usually if the patient is stable enough, then we may try to further stabilize the patient before we do the PCI, but we also don't have much evidence on how to select the time to do the PCI. Usually, if we have all the support device, let's say we have impeller in the first time, then we will do all the PCI at that time. But because we don't have impeller, we think IBP is not enough to support the patient, so we have no choice, but we have to postpone the PCI to the left main. So I think we don't have a good strategy to select the timing. But if we have everything at that time, we will do everything.
So can I?
Thank you.
I just want to add two quick comments. If this left main was in the setting of STEMI and shock, then revascularization at one sitting would make good sense with support. You elected to do a stage, and so I would agree, if you hadn't been pushed by the shock occurring before the second procedure, you could have waited weeks or longer, perhaps. In that age group with a total right, if you got the LED going, that may have been sufficient. The circumflex is an unknown, although it looked severe. And though, of course, in those lesions that are not visibly critical, then FFR in that setting might be also helpful for guidance. It doesn't automatically indicate you need to do it, but at least you would know whether it was potentially a culprit. I think we don't know what the best timing is. We have to individualize. But if you're going with an Impella on day one, I would try to go for complete revascularization.
Thank you, Ivan. And then we have limited time, so we have to move to the next presenter, Dr. Balaj Beretta from Netherlands, please.
Hi, hello everyone. Thank you for the kind invitation for LMHO. I would like to share my unforgettable left main PCI case. Can you see my slide?
We can see your slide. It's perfect.
That's great. That was a case from my early phase of my learning curve. And this was a 73-year-old male with a long medical history, including colon cancer and lung cancer. He was of cancer during the presentation. He had also hypertension, treated hypertension and diabetes mellitus. The patient had firstly the symptoms of reflux, but the GP sent him home, and a half day later developed sudden onset of shortness of breath, and the ambulance intubated him and transported to us with this ECG, and he also received dopamine due to cardiogenic shock. On the ECG was clearly seen a posterior MI, but also ST depressions lateral and ST elevation in lead 3. The patient arrived in a relatively stable situation with dopamine perfuser, and my supervisor was at this moment busy with a young male who was presented with an anterior STEMI on the cath lab. So I had to start my own diagnostic coronary angiography, and was clearly an approximately occluded circumflex with a diffusely diseased left main and a diffusely diseased LAD, proximal LAD, which was significant. From the other projection, can you see the proximal LAD lesion, and the right coronary artery was a small diseased vessel. The patient was relatively stable. So I do the wiring with the BMV in the LAD, and I could advance the pilot 50 into the circumflex with the drilling technique. The patient received on the table aspirin and efdifibetid and the dopamine. We continue the dopamine. At that time, I didn't implant an IABP. So my supervisor was still busy in the other cath lab, so I had to start the procedure, the PCI procedure. I started the opening of the circumflex coronary artery, which was successful with small balloons, and the flow was 30 millimeters in the circumflex, in the dominant circumflex coronary artery. I implanted a shorter stent distally, and I have chosen a culotte technique for the left main. I implanted the second stent in the left main toward the circumflex, and then after predilation toward the LAD, a third stent from the left main to the proximal LAD. So this was the primary result after the culotte, and then I did a final kissing balloon inflation and then a proximal optimalization in the left main. So I was happy with this result. At that time, this was my first left main PCI in a cardiogenic patient. And I was really happy with this, and also my colleagues. The patient did very well. The inotropic could stop in the first 24 hours, and the enzymes were also moderate, relative moderate, seeing this big territory of ischemia. And the ECG also normalized, and the patient was successfully extubated on the second postoperative day and was admitted on day 7 to cardiac rehabilitation. But the story of my patient didn't end here. He also had a routine control angiography at 4 months, which showed a good angiographic results. But the patient, after a half year, had current GE bleeding, and the control colonoscopy proved a malignant colon polyp. So the patient needed to operate after 7 months of the left main PCI, and the patient was on clopidogrel monotherapy during the time of the surgery. But after, so within 24 hours after the surgery, the patient hemodynamics collapsed, and the first differential diagnosis was, of course, stent thrombosis, but it was not the case, happily, because ECG was normal, relatively normal, and the final diagnosis was a massive pulmonary embolism. But the patient luckily completely recovered after 1 month of intensive care. So that was my case. Thank you for your attention.
Thank you. Very nice case. You did very well, and patient one another big problem, but recovered very well. Congratulations. So one of my question is, what is your antithrombotic therapy on this patient?
So this was in year 2014, and in that year we didn't have any other possibility to give than clopidogrel and aspirin. And in the first 1 month, we gave 2 times 75 milligrams clopidogrel for this patient.
That I means after massive pulmonary embolism. What is your?
Oh yeah. So after the pulmonary embolism, the patient received clopidogrel monotherapy for the thrombocytes, and and had an LMVH as anticoagulant in the first month.
Yes, I also have a very similar experience for my first left main case. So my senior doctors, Dr. Bark and many Barks in my cath labs, told me that you could do the left main case. So I had. So I asked my senior doctors, please be in the cath lab. I would do the left main PCI in this afternoon. But when I started my cases, nobody in there. Yes, I felt sympathy with it when I saw these cases. So I'd like to ask to the Dr. Juicy in Japan. So what is the best way to teach the complex PCI? What is your practice to teach the complex PCI in your junior doctors? How to teach it? What is your manner?
Yeah, okay. I think, do you hear me?
Yes, I can hear you.
Okay.
We can't see you.
I think the most best approach to treat left main PCI for young doctors in the elective case and good ejection fraction and not so long region, just balance stenting the cases. So it's left main PCI, the first attack for the young doctors. One stent, it's related, it may be achieved by one stent technique with a kissing balloon. It's the best case for the young doctor, I think. But emergency case, if you don't have the senior doctor, you have to do. So before that, you have to do many cases with sub operator for the emergency, I think.
So what did your cath lab in United States, Dr. KERN?
Yeah, so I think your question's very good. So there's two things I wanted to ask. One, I think in teaching PCI to young fellows is challenging, and you have to take them over time and escalate their responsibility for the procedures. You know, so first it's guide, and then it's wire, and then you get into more complex, and that's just a matter of exposure and time. The comment about what do you do if there's no senior doctor present, that's more challenging. As long as the junior doctor is qualified and completed his training, he proceeds. But if you're just a fellow, it's a little more dicey if there's no supervisor around. The institution is at risk for problems if you don't have enough people to take care of the patients. It rarely happens. I think you managed this superbly. And the question was, did you need, I forgot whether you had a balloon pump or an impella in, but it looked like you got through without either. One question is, what is the shortest duration of antiplatelet therapy, dual antiplatelet therapy, you would give to such a patient? You put a left main LED stent and circumflex kissing. What's the shortest duration? Would it be a month, 2 months, 6 months? Because obviously the colonoscopy occurred at 7 months, and you probably had to stop the problem. So I know there's some stents that require very few days of dual antiplatelet therapy, but we don't have those yet. What's your view on that? I'll ask Dr. Berta, and then perhaps one of the audience.
Yeah, thank you for your question. So to be honest, I was very happy if to be able to give the double antiplatelet therapy for a half year by this case. So I was not very I didn't have fear to get a stent thrombosis after a half year. I think the minimal duration is three months.
3 months. Obviously, the 7-month interruption of dual antiplatelet therapy didn't cause stent thrombosis. It was probably incidental to have venous thrombosis and pulmonary embolus due to the colonoscopy and the cancer. So I think that was good. And we could probably shorten that, even for complex left main, shorten the duration of dual antiplatelet therapy because the stents in 2020 are so very good. Just my own thing. I did want to ask one more thing. No imaging was used at your case, Dr. Berta, and I think limited imaging was used in the first case. Are we not using IVUS enough for left mains?
That case of mine was done in Hungary, and in that time we didn't have BG for intracoronary imaging. But of course, we would like to use IVUS or OCT.
Sure.
For sure.
And Dr. I don't see you. Ivan Tsang, are you still with us? Did Dr. Tsang use?
Yes.
Hi. Did you use IVUS in your case? I don't recall.
I did use IVUS.
Okay. So I know IVUS results improve our outcomes, but it's very hard to do after a difficult case. And you're just happy to get out of the cath lab with the patient alive sometimes. So I am completely understanding of that. But we should try and do IVUS for left main. That's kind of the minimum use of IVUS. If you're going to use it anywhere, that's where you use it.
So maybe we go for the third cases because of we still need to go through a few case presentation. So Dr. Bar Chen Hu, so please start the third presentation.
Yes, sir. Yes, so can you hear me? Yes, so I see the screen here. Sorry, maybe the problem is the slide, so wait for a few minutes. So can you see the slide? Yeah.
Okay,
so,
we can see.
Yeah. So here's the school chairs and my college, and so I would like to give my presentations with the title "My Unforgettable Case." We use modified geoballoon techniques in left main intervention. And so here's the background of the patient. Is a 79 male patient. The risk factor is hypertension and dyslipidemia. And the patient admitted to the hospital because by chest pain several days before admission. And in the ECG, it shows no SD elevations or no SDT chain and increase cardiac angina. And in echo, it shows no word motion abnormality, and the LVEF is in low range, it's around maybe 40%. And so we decide to move the patient to the CAT. And so here's the lesions. When you see in the cord, can you hear clearly? Yeah. And so in the cord view, we can see this maybe the left main bifurcation lesion is Medina 111. And so in the cranial, we check how long the lesions is. And so as routinely, we check the lesion in the 4-chamber view as well as in the spider view. It shows maybe the localized the lesion in the left main bifurcations is Medina 111. And so we check the lesion in this RCA is maybe the moderate stenosis in the distant RCA. Here's in the image. And so the cabbage will consider for the patient, but as many is not, but like many Asian patients, the patients refuse the cabbage. And so the question is, should we accept this case for the PCI? Because here maybe the classified to the high risk PCI-K. And so any chance any PCI chance for the case, because the obstacle in my center is ECMO impella is very high cost. Just only but it's not available ECMO, And so for this kind of lesions, Medina 111 is it needs to save time for the procedures and less manipulation in the left main bifurcation. It could tend to the hemodynamic collapse and maybe the risk factors for the difficulty to reaccess the sub to the cells because maybe it's very massive, or maybe it's in emergencies case we can use this SKS then. SKS or maybe the mini class to stand techniques for this kind of lesion, but maybe for the long-term results, it is shown just maybe the culotte or maybe the K class is better for this kind of lesion. And so in case we have to protect both branch, but in case we get the first and two, maybe the main or side branch is maybe have maybe the 10% to occlusion of side branch, and maybe 1/3 of the side branch occlusions can be reopened. But how we can maybe what technique we can use to keep the side branch open? We revise maybe the modified gel balloon technique in the paper published in the PCI 2016. Maybe it's a data show is maybe the around maybe the 1.6 only minority cannot be across, and no side branch occlusion in maybe around maybe 250 case. And so in fact in our center before this case we have no experience about left main bifurcation with a modified gel balloon technique, but we also have maybe experience about use a modified gel balloon technique with the off-label stand or balloon, or maybe the use gel balloon diameter is over 2.5 mm. And so the plans for this case we use is a femoral access is 7 French. We have only the IBP supports for this case, and the guiding catheter use 7 French, ABU 7 French, and Warhorse Y is a bow run through. So here's after wiring both branch, we use simultaneous pre-dilation with the Tajuna with the compliant balloon. With the compliant balloon is Tajuna 2.520. And later, we after pre-dilation, we check the angle to check how long the lesion, as well as maybe how the carina modify. And so then later, we use a modified gel balloon technique as below. We engage the stand into the left main LAD. Then maybe gel balloon is with the stand use anti-master 3.5 33, and the gel balloon is around maybe 2015. And then later we inflate the stand first. Inflate the stand left main LAD first. Then pull back the compliant balloon. Then after we maybe the inflation bow to the nominal rate, then spool out both of the balloon stand and the balloon and compliant and balloon. And then later after to do the stand from the left main to LD and do modified gel balloon technique, the flow we check the flow in the main branch and side branch is also good. And so we decide to do the culotte stand. We decide to do move to the culotte standing and POT the lemon LD with the NC balloon is 3.520. And so rewind as well to do this for the culotte standing. Here's rewind to from the lemon to the serve and open stand strut with a compliant balloon, and then to do the culotte technique with the anti-master 3.528. And so here's the views. And so here's for the next image after we put the stand from lemon to sub, and then later to do the final kissing balloon and to do the POT. When we to do the POTs in the left main, this may be the chi of the balloon as well as maybe it's the chi and the side of the NC balloon here. Then later we check the IVUS in the lemon LEDs to check where the stand struck, as well as maybe this maybe structure of the stand. And here's here in this right view, you can see here we can see this maybe to check the flow of the LVD as well as the stand, whether stand deformities. And here we can see in the quarter view as well in this cranial view, the flow is good. And so we check in another view for chamber view as well in the quarter view. And during the procedures with this kind of techniques, the hemodynamic is stable. And so after finish the procedures, the patient is stable. And so we discharge patient 3 days later with no complication. And so in my case, I think this modified German technique is useful to reassess for the side branch in bifurcation intervention, and maybe could be other tables option for lemon bifurcation intervention in a certain case. But in the end, also my question is that in which case we shouldn't do this kind of techniques for lemon bifurcation intervention. And so that's all. And thank you for your attention.
Thank you for nice presentation. Do you have any comments or question from audience?
Hi.
So,
Hi, it's Ivan from Hong Kong.
Many questions.
Okay, you
talk about
Hong Kong.
yeah. Talk about yeah.
Yeah. So yeah, I have 2 questions for the presenter. Yes, the first one is yes. First, it's so great that you show the modified gel balloon technique in the left main intervention. So to me, is the first question is, would you still follow for the modified gel balloon the size of the balloon? Would you still choose like is the half size of the main branch stand as suggested by the original description? And so how would you choose the size of the balloon? And the second question is for the modified gel balloon technique, to me seems is still sort of the professional stenting strategy. So if you decide to have the upfront 2-stent strategy for the complex bifurcation, so maybe it's not that useful for the modified gel balloon technique. So if, for example, if you think you use the modified gel balloon technique first, and if there is any case that you have the side branch closure, and then you will have to say the belt out 2-stent strategy. So to me, the concept seems to be more of like this strategy. Thank you.
And so thanks for your comments. So I answer first your question. Yeah, as for the balloon we use in gel is usually I think that in fact we usually we have maybe experience about off-label balloon, and so also we can use even with we can pull back the inflated balloon even with the diameter is over 2.5, and so maybe in case we can also use the 2.5, but in this case I don't want to maybe any complication, and so for sure I just only use 2.015 to maybe to easily to pull back, as well as maybe we have maybe to confident to no complication in cases we can pull back. In this case, I see maybe there's no calcification, and so that's maybe I use maybe 2.0. Yeah.
So can I ask? So excellent case. I'm not clear for myself on why I would pick a jailed balloon versus a jailed wire. Does it change my approach greatly? And what's the advantage of a jailed balloon?
Because that's maybe as for this case also those maybe now 111, and so maybe in this the angle of the circle to the LD is not extremely acute. I think that I have experience for maybe bifurcation in this LD, and so some things in some case you cannot predict exactly after you put the stent from left main to LD, whereas maybe the low chance to reaccess the circuit. So in this case, maybe if you have maybe maybe even just a small percentage of a side branch occlusion is maybe to tend to hemodynamic collapse, and so I think that's to rule out any percent of the side branch occlusion, and so I use this technique. So that's what I think for this case. That yeah.
So I have two short comments. First of all, I think this case is one of the most toughest complex case. Wiring is I think most important part. If you wanna put the wire where, and I think definitely guaranteed the procedure success. Second one is about the gelled balloon technique. And recently, and people 5 years ago, there is no concept of gelled balloon technique, and recently introduced in the EBC group for treating the complex PCI case. But we in Asan Medical Center, we do layman case at least 300 per year, but we don't use the gelled balloon technique. If you think about the DK crush technique, there are many steps. We require 7 or 8 steps. If you consider gelled balloon technique, there are additional 10 step, 11 step, 12 step, much complicated case. If you're gonna do layman case, the timing is very important. If you delay the timing, patient can be catastrophic, is hemodynamically unstable. So as you mentioned, Dr. Morton Khan, the gelled wire technique is most cases we can successfully pass the guide wire almost all cases. So I think gelled balloon technique should be limited, some selected as a very complex case.
Yeah, thank you.
Yes, hi. Hi, I'm Chapong Ho from Hong Kong, and congratulations, Dr. Hai, for your good case. I have a few questions. First of all, I would like to ask, what is the use of the first kissing balloon in simultaneous inflation in your case? And second, after your modified gel balloon, did you do port of the left wing to ensure that you have adequate left wing coverage before you rewire the left cert? And third, if you are really, I think the wiring of the left cert seems difficult from the underlying angiogram. So would you consider some crush technique to ensure patency of both left main LAD and cert instead of doing the culotte stenting?
First is that I usually for this kind of Medina 111. So just I would like to pre-delete both sides at the same time. To maybe is to not to prevent maybe carina shift. To take time to rewire. Take time to maybe to do one more pre-dilation. And the second is that the second question is that I usually maybe small balloon because we cannot exactly predict how maybe it's deform the left main stem, and then maybe when we rewire from the left main to the sub, it will be to come to the in or out maybe stand swap. And then after we simultaneous predilation, we check the flow. In case the good flow, we can maybe to do maybe the POT. Then later we will wiring from the left main to the sub.
Okay, thank you, the audience, and thank you, presenters. Nice case. So let's move to the next presenter, Dr. Kang. Would you please? Dr. Kang, I can hear you. Please unmute.
Can you see my slide?
Okay. Yes, I can.
Okay.
I can see your slide.
Thank you for inviting me as the case presenter, and thank you and nice to meet you everyone in virtual online. Today my case is the case PCI with a heavily calcified left main disease. I will share my case with my principal in our center's principal while during the left main PCI. The patient is 72-year-old male and with unstable angina. And he has a history of hypertension and dyslipidemia, and taking aspirin and clopidogrel and statin and beta blocker and CCB and ARB. There was as depression at before and 6, before to 6 at stage 2 during the treadmill test, and thallium SPECT showed a large defect in the LAD territory. Echo showed normal LV, and we took the diagnostic angiogram, and it showed significant left main disease and circumflex ostial disease with heavy calcification. Very diffuse disease with heavily calcified lesion. And the RCA showed diffuse disease. And we checked the FFR, and the result was 0.82 during the hyperemia, and it was deferred. And with a discussion with the patient and the patron, we decided to PCI the heavily calcified left main lesion. Yes. And in this very hard lesion, I do not perform the PCI just after diagnostic angiography. I stop the angiography and take time with the patient and patron and myself and my team, and then begin procedure after 1 or 2 days later. And I prepared a large bore guiding cutter with strong backup force with a femoral approach. I used the 8 French JL cutter with side hole with femoral approach to take the maximum backup, and a large bore to introduce many devices safely and effectively. And I prefer jockeying for this kind of case to the procedure freely in the left main. And I wired LAD and circumflex with carbon microcatheter. It took time, but eventually succeed. And then I always believe that the key is intracoronary imaging for the best procedure of the left main PCI. The data showed that with the IVUS guidance, you can select bigger stent and bigger balloon when you use IVUS. And also our data showed that with the IVUS guidance, the left main PCI showed better long-term outcome. So I always use intravascular imaging, and I prefer IVUS for the left main case because of the ostial visualization than OCT. And I ballooned with the Relay Compliant 2.0 balloon, and then took the IVUS from the LAD. It begins from the mid-LAD, and you could see the diagonal branch and very diffuse disease. The vessel size is about 3.0 here. And you can see the septal and diagonal branch. And at the proximal LAD, the calcification is very severe. And there is an eccentric plaque with a vessel size of 4.0. You can see very thick calcification. And the circumflex comes in from the 6 o'clock. And at the left main, distal left main, there is very thick ring calcification. And at the shaft and ostial left main, there is mild disease. You can see as the angiography, the IVUS shows very severe calcification here. And I also took the circumflex pullback of the IVUS. And from distal, very small vessel. And then in, and the proximal circumflex size is about 3.25 maybe, and then relative remodeling, and then this is just the os of the circumflex. You can see at the just ostium of the circumflex here, there is very severe calcification and stenosis at the just POC, polygonal confluence of the left main. So the option is 1, to cross over, 2, a front two stent technique. So in this case, because you see in the angiography, the circumflex looks small and the risk of gelling is very high. And you can also see the severe calcification in the circumflex. I decided to upfront 2 stenting for this left main bifurcation case. You can see the IVUS. And I always believe that aggressive pre-lesion modification before stenting is essential for calcified left main PCI, not only for the calcified disease, but also for all PCI. Pre-lesion modification is very important. So I used NC balloon 3.5 up to 24 ATM. I could apply high pressure because I evaluate the vessel size in the IVUS, and circumflex with a 3.0 NC balloon up to 22 ATM. And then with I planned the balloon crush and circumflex stenting with a 2.75 up to 14 ATM. And then I believe that open side branch ostium as large as I can when I implant side branch stent is very important. In the pre-combat 2 trial analysis, the left main bifurcation, after left main bifurcation stenting, the recurrence mostly occurred in the ostium of the side branch. To minimize this risk, to optimize the side branch ostium after stenting and maximally inflate and maximally widening of the side branch ostium before crush is very important. So with a 2.75 stent balloon, when pulling out the balloon, I applied 20 ATM and then reintroduce the 3.0 NC balloon and applied 28 ATM up to the highest pressure as I can, and then perform the balloon crush with a 3.5 NC. And the rewiring after balloon crush with a choice PT, and opened the side branch strut with a very small 1.25 and 2.0 balloon to open the side branch strut and to utilize the rewiring after stenting. I did not perform the decay crush because I believe that just the opening of the side branch is important. And then stented left main to LAD with the 3.5 giant stent up to 12 ATM. And because there was some distal edge dissection, I added one more stent. And what is next? A side branch rewiring. The most important thing before side branch wiring is the LAD stent optimization. I applied NC 3.0 and 3.5 up to 28 ATM, and with the IVUS information, I applied 4.5 NC balloon at the just ostium of the left main for a stent optimization. I think the main branch is more important than side branch, and main branch stent optimization after IVUS evaluation before rewiring makes side branch rewiring easier. And before side branch procedure, main branch stent, and particularly in the left main and POC area, should be well opposed and fully expanded to utilization easy side branch rewiring. And because after part, you can see that the stent strut is widened, and you can easily reapproach to the side branch. And the high pressure optimization before rewiring is the concept of the part. And I think that the precondition for easy side branch rewiring is first, open side branch ostial stent widely when you put the stent, and second, main branch stent optimization before rewiring. And with the aggressive optimization, and I could wire the BMW wire into the side branch easily, and then apply the relay to 1.25 and 2.0 balloon, and apply sequential high pressure into circumflex with the 3.0 and 3.5 with the left to the LAD. And then perform the final kissing balloon with the 3.5 and 3.0 up to 10 ATM. The significant stent cross-sectional area is obtained by sequential high-pressure ballooning, not by final kissing balloon. The goal of the final kissing balloon is to place carina in the right place, so high pressure is not necessary, not essential during the final kissing balloon. And for the left main optimization, I applied 4.5 NC up to 20 ATM, and this is the final angiography. There was severe calcification, but I tried my best to obtain the largest stent area as big as possible. And this is the LAD and circumflex pulve from the distal LAD, mid LAD. You can see the stent was well opposed. I want to dilate further, but I could not. I tried my best with a 3.0 balloon up to about 30 ATM. And the Prof LAD, the stent was fully expanded. And here is the circumflex ostium. You can see the very small carina. And here was the narrowest portion with the ring calcification. And I could obtain the lumen area about 10 square millimeter here. Oh, sorry. Here is the circumflex. You can see the very small, very short carina here. And here's the left main shaft, fully expanded after aggressive balloon dilation. And it's the ostium. And small protrusion in aorta. And the circumflex stent was well opposed and well dilated. And there was very discrete disease at circumflex ostium. And I did my best to dilate the circumflex ostium, but the lumen was small, but it was about 5.5 square millimeter, maybe. Yes, the circumflex ostium was about 5.5, and circumflex shaft was 753 on the IVUS MSA, and POC and left main LAD was more than 9 square millimeter. And this is the final angiography. So this is my personal rule for crush technique for left main PCI. I always use the IVUS, and I think that is the key for bifurcation stenting. And pre-lesion modification is crucial for calcified lesions. I must not underestimate the calcium always. And large opening of the side branch stent ostium and the main branch optimization at the POC area is important for easy side branch rewiring. Stent area is obtained by sequential high pressure ballooning, while final kissing balloon is to place the carina in the right place. Final IVUS surveillance and correcting suboptimal result guarantee the favorable long-term outcomes. Thank you. Thank you for attention.
Thank you very much, Dr. Kang. So thank you for your very nice explanation of step-by-step the crush technique in the very calcified left main case. Do you have any comments or question from audience?
Yes, I have one question, Doyen. So thank you for your excellent illustration, very detailed, very educational. So I wonder whether you have considered the use of rotational atherectomy before you use the NC balloon to treat the calcified lesion in the very first place?
Yes, the rotational atherectomy would be an option for the left main to LAD direction. Left main to circumflex direction is very acute angle, so it's dangerous. So if I try the NC balloon and if that was not fully inflated, then I would use the rotational atherectomy. But in this case, luckily, fortunately, the NC balloon dilated very well after 3.0 and 3.5 NC balloon, so I did not perform the rotational atherectomy. In this case, I try the NC balloon, and if it doesn't work, and I use the rotational atherectomy in this case?
In my practice, I usually is afraid of when I first use a big NC balloon, then it will create some dissection. Then after that, even if the balloon becomes underexpanded and I use rotablator, I will worsen the dissection. So in my practice, I usually try to do upfront rotational atherectomy instead of using a big NC balloon. But I think in Hong Kong, maybe we are a little bit lucky that we still have the shock wave. And in case there's some dissection created, like what you have done in your approach using a big NC balloon first, maybe if the NC balloon cannot open, I may try a shockwave balloon.
As I agree to your opinion, the upfront atherectomy would be a very good option, a very good treatment strategy. But for me, to perform the atherectomy is a little bit difficult, so I prefer balloon at the first time. But how about the role of the shockwave balloon in this case? Because I don't have the shockwave balloon, so I'm very curious about the role and effect of the shockwave.
I think from my experience in your case, because shockwave is very effective in concentric calcium, but not very effective in eccentric calcium. I think the most concentric part of your calcium is located at distal left main, so shockwave at that part may help a bit. I'm not sure whether it functions perfectly, but I do think it may help a bit. But for the proximal LAD circumflex, actually those are eccentric calcium, that shockwave may not be working very well at that area.
Can I add something? Can I add? Thank you, Un, for excellent case presentation about left main. I like to add, you adopt that there is several techniques for left main bifurcation. All of you know, keloid and decay crash, and positional stenting followed by bailout technique. We use the crash technique, but we know that the latest trial, decay crash trial 3, shows that the superiority and long-term result of ISR about the left main, particularly left main bifurcation stenting, is superior. But I like to know which technique for this this procedure is done by two-stent technique, not as a bailout. It is still elective. So what about Dr. Un comment? Why you do not go to the decay crash or keloid rather than crash for left main? For left main, other bifurcation technique, it's okay. Left main, LAD, D1, LCX, circumflex OM is crash technique is okay. It's less time consuming, less. But for left main, what is your comment about why you adopt this crash technique rather than decay crash?
Very good question and comment, Dr. Amar. I prefer crush technique for the left main or bifurcation technique stenting because of the one, I think that the main branch is more important than side branch. And the crush technique is, I believe, that better for keeping the main branch bigger than keloid or other technology. And second reason is that I am more familiar with the technique because many studies, not head-to-head, not many head-to-head comparison data from the bifurcation techniques, but in the real world data, many techniques show the similar clinical outcomes. So I believe that use your best practice, use my best and familiar technique is the important, I think, because I use crush usually, so I am very familiar with the technique, so I prefer that. In some case that we need other techniques, then I can use keloid or other things, but I usually prefer the crush. And with the decay crush, I also think that decay crush is very good and very good technique and very shows a very good data. But I do not routinely perform the decay crush because first I believe that with a very high pressure side branch opening and in the and in some case with a small or calcified side branch opening, then I did the rewiring and balloon to open the side branch ostium before main branch stenting, and that would be, I think that would be sufficient for the crush technique. So I also want to evaluate whether DK crush or mini crush, mini classic crush, which would be better. I wanted to randomize or to take trials comparing those of the techniques, but I need more data for that.
Can I make
one lesson is that the familiar for the interventional cardiologists, one of the lessons that the technique you adapt or you perform, it should be a familiar. Familiar is one of the parameter. Which technique is familiar for individualization? It is the prediction or the operator's concern. So which technique is he or she felt familiar? The familiar is very important for the interventional cardiologists. Thank you.
Can I make a short comment? Yes, so I'm Shoji from Japan. So very nice result. And so you mentioned, so the IVAS for left main is very important. So I agree with you. And so I have one message for especially for young doctors. So for this kind of calcified left main bifurcation case, and so especially large bifurcation case. So you didn't use rotablator, but so maybe I will use IVAS for left I will use rotablator for circumference. Maybe it will be effective, but you could open up with non-compliant balloon with high pressure. It's okay, but after open up with balloon catheter, we should check IVAS again, because sometimes the wire migrates into the dissected lumen. At that time, if after balloon dilatation, it wasn't enough. At that time, doing rotablator or putting stent, sometimes it will locate into the dissected lumen. Also, it so different word. So the behind of the calcium chunk, it is very difficult situation. So that we should check where the wire is located after the open up of the left main calcified lesion. It's very important. I saw so many cases of trouble in left main calcified lesion. So it's my comment.
So I think a very important and very nice comment.
May I have a question?
So we have one more presenter. So let's go to the next presenters. Dr. Mutulu from Turkey. Are you ready?
Yes, I'm ready.
Can you share your slide? Dr. Mutulu?
Yes, I'm trying.
Very busy.
Very busy.
Screen.
Oh. I couldn't see.
Make sure you open the Wi-Fi. Yes.
So while Dr. Verriol is finding his case, I just want to mention, I think advice from our colleague to stick with the technique for bifurcation that works the best for you and that you have the most experience with, and not try and do every different technique. I think the DK crush are probably the two most popular if you're going with two stents. Learn those well, be careful with them, do your ballooning, do your kissing, do your post-procedure imaging, and stick to something that is comfortable for you to work. That will give you the best result. Otherwise, you may have some trouble mixing and matching in different scenarios. At least that's my own view on this. I try not to make it too complicated, and I like to teach the fellows a simple approach as well.
sir, we can see your slide. Yeah.
Do you see my slides?
Yes, sir, we can see your slide.
Okay, thank you. I will present a case with acute severe mitral regurgitation during left main PCI. This is a 98-year-old non-diabetic male with COPD. He was admitted to emergency department with shortness of breath, tachypnea, and hypoxia. First, he was hospitalized in the intensive care unit due to pneumonia and decompensated heart failure. On echo, left ventricular ejection fraction was normal with minimal mitral regurgitation and no regional wall motion abnormality. He was transferred to coronary care unit because his blood troponin was positive. He was dependent on nasal oxygen inhalation. Coronary angiography was performed on the 7th day of hospitalization with partial stabilization. This is spider view. You see severe stenosis in the left main with some calcification. The ostium of the circ is not clear. This is an ulcerated plaque. And with respect to flow in the LAD, circ flow is slow. And we realized that there is stenosis in the ostium of the LAD. This is a true bifurcation. RCA was codominant with minimal disease. Invasive cardiology was new in the state hospital where we perform left main PCI. It was only center to perform PCI and CABG in the city. Practice and equipment were also limited in that center. Transferring the patient to another hospital is not easy and not accepted by the patient and his family. After coronary angiography CABG is indicated, unfortunately, cardiovascular surgeons decided that this patient was inoperable due to impaired lung function and high estimated mortality rate. The patient cannot be removed from the coronary care unit as his condition has not improved. I was on my vacation very close to that patient and my colleague called me for help. We planned to perform the EKG crash for this patient. This is the procedure. Unfortunately, we failed from the beginning because circ ostium was balloon uncrossable lesion. Our plan was first predilatation of the circ, but we failed, unfortunately. We do not have equipment such as microcatheters, different wires, or rotablators to overcome this condition. We performed side branch anchoring, inflated the balloon in the LAD and pushed the circ balloon, and unfortunately failed. Meanwhile, blood pressure was decreasing, oxygen saturation decreasing below 90, heart rate was increasing after wiring and delivering devices in the left main stenosis. Because of worsening hemodynamic parameters, we predilated left main and started to perform left main to LAD crossover stenting. We planned reverse crash stenting for the circ at the same session. This is predilatation of the left main. You see prolapse of the circ wire from the previous efforts. There is a dissection of the predilatation. We implanted 4O stent. You see the flow in the circ is markedly decreased. We performed both with 4.5 NC balloon at 16 atmosphere. During left main to LAD crossover stenting, blood pressure had been markedly decreased. Around 60-40 millimeter mercury, the patient slowly lost consciousness. Deep hypotension unresponded to IV isotonic saline. After a period of compensation, heart rate and respiratory rate decreased. Respiratory arrest occurred and treated with AMBU. CPR was performed for a few minutes. We do not perform defibrillation because the rhythm was normal sinus rhythm. Later, spontaneous respiration started and heart rate increased after IV adrenaline, dopamine, and noradrenaline. but blood pressure has still been very low, around 70/40. On-site echo showed severe mitral regurgitation. An intra-aortic balloon pump was implanted. Then we started for reverse crash stenting for the circ. Rewiring with choice PT2 was possible, and we lately found low caliber balloon for predilatation. Unfortunately, native operator and cardiologist decided to stop the procedure, and they delayed reverse crash stenting at another session. There was an ulceration in the plaque. You see this from the previous view. It is not a dissection. This was the final angiogram. Later, my colleague reported that acute mitral regurgitation had been improved to mild mitral regurgitation on echo in next few hours. Meanwhile, clinical parameters also improved more than ever before. Intra-aortic balloon pump weaned off on the second day, and the patient transferred to inpatient department. He discharged on the 6th day of the procedure. The patient visited outpatient clinics 2 weeks later. Another cardiologist examined him and unfavored stage reverse crash stenting for the circ. Medical therapy was only ordered. Days later, the patient admitted to another hospital with respiratory distress and intubated in the intensive care unit for mechanical ventilatory support. He unfortunately died 2 days later. Intraprocedural loss of circ perfusion could result in severe acute mitral regurgitation with severe hypertension during LFM PCI. Assist devices might help for hemodynamic stabilization and gain some time to restore circ flow. The full restoration of the circ perfusion as soon as possible would be important for good prognosis. As an operator in another institution, you must know the capability of the team and the cath lab before doing a left main PCI. Complete equipment should always be a must. If not, an elective left main PCI should not be performed except for unstable patients without any other options such as emergent CABG or transfer to another center. Thank you.
Thank you for the nice demonstration, Dr. Butul. So, is there any question and comment from the audience?
Thank you. I'm Chuck Bong-ho from Hong Kong, and thank you for sharing such a nice case with very good educational value. In hindsight, would you still perform the PCI to left main to LAD if you could not dilate the left cert?
This patient was stuck in the coronary care unit. We cannot transfer patient to rehabilitation clinic or ordinary clinic. We don't have any chance to discharge this patient, and patient does not want to go to another hospital. Our patients want to die at their hometown. Unfortunately, there is no option in the city, and I am a guest in the city. I don't have primary responsibility for that patient. And in my institution, I stopped the procedure in that stage, and I have many possibilities. In Istanbul, there are many hospitals, many expert hospitals, and I have more equipped cath lab in my institution. I have done many cases, over 50 cases in my institution. I have good results for patient no mortality. I have good results short term and long term. Well, in that case, patient deteriorated during the procedure. If we don't go on the procedure, he will die. Because of that, I decided to continue the procedure.
Okay, thank you, Dr. Mutulu. This will be the last cases.
No, I think we still have one more cases, but because we are overrun, I'm not sure whether everyone want to still proceed for the last case because Hugo's get a case to present today actually.
Okay.
So maybe let Hugo just finish his last presentation. Hugo, are you here?
Hello. Can you hear me? Can you hear me?
Yes, I can hear you.
Okay.
Hear you.
Wait for a moment. Can you see the screen?
Yes, sir. Oh, Dr. Hugo Tang, long time no see.
Yeah. Hello, Asan friends.
Sorry, I missed your name.
Yeah. Okay. Hello, An, Park, and
Actually, most are familiar face.
Many familiar face from Hong Kong. So, I prepare a case for today. So sorry for the overrun. So first, I have no conflict of interest. So the topic is unforgettable left main PCI. So brief case summary is a 67-year-old male admitted to my hospital. At the hospital earlier this year, associated with dyspnea and also the chest discomfort. His vital on arrival is lowish blood pressure, tachycardia, and dyspnea actually have some desaturation. His demographic characteristic, he was a smoker and has diabetes. So this was his chest X-ray on arrival and the EKG on admission. So in summary, this patient got profound shock with respiratory failure, which required invasive ventilatory support. And on arrival to my hospital, he required high-dose noradrenaline infusion and had an IABP inserted for the circulatory support before transferred to my hospital. And he was sent to my hospital for urgent intervention. So this was the initial laboratory parameter. He got slight elevated creatine kinase, elevated troponin, and the lactate level was elevated also. We have done a bedside echocardiogram for him. He got very poor global LVEF around 20, and most worse at the basal inferior and apical anterior, and the IVC was engorged. So this was the initial angiogram. So we can see very severe left main, ostial left main, and also the distal left main lesion. And also very diffuse LAD, proximal to mid LAD lesion, and also diffuse calcified lesion. So we use the right femoral approach for this gentleman. And you can also see the circumflex from this view. Actually, the circumflex is chronic total occlusion with the retrograde filling from the left system down to the distal left third. So for the right system, also very diffuse disease from the proximal to mid RCA. He got PDA and a very tiny PL branch. So in summary, the left main, he got very diffuse left main disease from ostial to distal left main, and also diffuse LAD with severe calcification, proximal and mid LAD subtotal occlusion. And the left third, proximal left third is CTO with a retrograde faint filling to the distal left third. And the RCA was also calcified with a long mid to distal RCA lesion. So overall, it's a very critical left main and triple vessel disease. So his operative risk is high, and he got a very high syntax score also. So because we have no on-site surgeon support and the patient was really clinically unstable, so we decided for ad hoc PCI. So our approach, left femoral is already IBP in situ. We use the 6 French JL4 guiding from the right femoral, run through NS guide wire, and we plan to do the left main and LAD crossover because of the circumflex CTO in view of the very critical patient. So we first pull bar to the left main and the proximal LAD with a 2.0 balloon. And then we try to stabilize the guide with another run-through guide wire. LAD is a very calcified lesion in the LAD. We cannot open with an NC3O balloon up to a very high pressure. So the blood pressure actually down to 40 with bradycardia, and we need to inject the intracoronary adrenaline, repeat the bolus to boost up the blood pressure. So we decided to stent the left main first in view of this very critical state before the severe LAD calcification. We stent with a 3.014 DES. And then we post-dilate with an NC3015. After settle the left main, we try to open up the mid-LAD severe calcified lesion by 2.0 balloon, a scoring balloon. But still we cannot open it. And we further pull bar to the LAD calcified lesion with a 2.5 balloon up to 24 ATM, but still cannot open. And every time we pull bar to the mid-LAD lesion, the blood pressure of the patient actually going down, and we need to give repeated dose of adrenaline for the blood pressure. So we use the OPN balloon. Is a ultra high pressure NC balloon to the mid LAD. Finally, we can open it with a 2.0 OPN balloon up to 34 ATM. Then we follow by larger balloon, NC balloon dilatation. And then below, we treat the downstream calcified lesion with some scoring balloon and NC balloon, 2.5. 2.0 scoring, and then 2.5 NC balloon. We do IFAS for sizing of the LAD and the left main. And then we put in a long DES from the distal left main to the LAD, 2.536. And we do some pulse dilatation with a 2.5 NC balloon. So further pulse dilate to the left main and proximal LAD with a 3.5 balloon. And we do a pulse IVUS after stenting. So sorry that I didn't prepare the IVUS image for you. So this is the final result. So for RCA PCI, we plan to do the RCA revascularization in the same section in view of the critical cardiogenic shock. So we use the JR4 guiding catheter and the guiding extension because of the poor guiding support, and also IVUS guide stand optimization. So we do some multiple RCA dilatation using the NC balloon and scoring balloon. So after the repeated pull bar to the RCA, and we put in the DES 2.2524 at the distal RCA. We put in the DES 2.2524. And then we stand up to the osteo RCA using a 3.5 DES. And we do some pulse dilatation up to 3.5. And this is the final CAG for the RCA. So for the progress of this patient afterwards, he actually got multi-organ failure, required renal support, hospitalized for 26 days inpatient, and the repeated echocardiogram show improved LVEF. So the latest progress, he was able back home, walk unaided, and resumed cycling. Okay, so this is the end of my left main cases. Okay, thank you for your attention. And thank you, the Asan Medical Center. Okay.
Thank you, Tang. Long time no see. Thank you, Thank you for very nice presentation. So because of limitation of time, we will have only one question from audience. No questions.
Hi, this is Ivan from Hong Kong. So thank you, Hugo, for your nice presentation. So I was just wonder, so how would you choose whether you would say have a stage procedures to all the coronaries, or you would choose to revascularize all the coronaries in a single setting? Because we have more of the complications or contrast, that sort of thing, if you have all the revascularization in one setting. Thank you.
I think in my institution practice, if the patient got cardiogenic shock, APO, then we try to have more revascularization. Of course, in that particular case, we won't proceed with the CTO due to the complexity of the lesion and also the critical state of the patient. But in case of cardiogenic shock with required I neutral or IBP, then we would try our best to revascularize all the vessels.
Okay, I think every presentation is finished. So I'd like to move. I'd like to ask to the Anthony Wang for the summing up the today's conference and then closing remarks.
Okay, thank you, Dr. An. So I think as one of the organizing committee, I would like to thank you, all of you, for joining us to the end of this wonderful webinar. And I would also want to thank Dr. Lam Ho and Dr. Yu KHU for as my partner to organize this event. And of course, we need to thank our mentor, Professor D.W. Park and Professor J.M. An, to mentor us